Okay, students, welcome to one more Prof Exams Made easy session with Pharma. We'll be starting with migraine, as I've told already. We'll not be spending up a lot of time. We'll keep it as crisp as possible, and we'll be discussing only those points pertaining to the exams. You just need to note down these points in your notes and write it down exactly in your exams. How important is this question? Drugs for migraine. You might land up most probably not some long answers. If a question is been designed as a difficult question, they might ask about drugs for migraine as a long answer. But usually, drugs for migraine would be one important short notes. Please note down all these points, my dears. Just we'll be talking about one diagram and two flowcharts. One diagram and two flowcharts. With this, we're going to be completing about drugs used for migraine. First of all, what is the pathophysiology of migraine? If the question has been asked in long answer, they have to write up about the pathophysiology too. As per pathophysiology from the higher centers, which means from your brain or from the cerebrum, any impulses which is traveling out from the from the outside of the body, like it might be a vision or a strong odor or any sound or anything it's going to be. From these higher centers, the impulse will come down towards this trigeminal nucleus. Inside the trigeminal nucleus, as the impulse comes down from the cerebrum towards the trigeminal nucleus, this end plate is going to get depolarized. Thereby, there will be influx of sodium, influx of calcium, which leads on to the release of already stored contents. What are the contents which are stored inside the trigeminal neurons? Here we are going to be talking about two important molecules. One is substance P, the other one is CGRP. Substance P, we know, which is responsible for pain stimulus to be sent down, and CGRP is nothing but calcitonin gene related peptide. I will write it down nearby. CGRP is nothing but calcitonin gene related peptide. This is primarily a vasodilatory vasoactive peptide. It's a vasoactive peptide, which means the action of this is going to be happening in the blood vessels. And this is primarily a vasodilatory vasoactive peptide. It's not a vasoconstrictive one. When substance P and CGRP are getting released out, as we know, trigeminal neurons, there are three major subtypes. What are those? We have the ophthalmic, we have maxillary, and we have mandibular. Ophthalmic and the maxillary neurons in turn will be moving on towards the meningeal blood vessels. The meningeal blood vessels will be supplied up with that. From the meningeal blood vessels, there will be release of nitric oxide inside the meningeal blood vessels. There will be release of serotonin. There will be release of, again, CGRP molecules. All of these things are responsible for vasodilatation and pain stimulus to be sent out. Well, that's how patient will be having a throbbing, very much severe throbbing headache. And of course, we know that migraine is associated with aura. There might be prodromal symptoms associated with the migraine. And patients might land up in severe nausea, vomiting too. These are the clinical features of it. I'm not going to the deeper perspectives of the clinical features because we'll just stick on to the pharmacological perspective because we are preparing for the Prof Exams right now. So whenever the question is being asked, you have to write down this pathophysiology or draw this diagram where we are going to be explaining about how migraine pain is getting developed down. With this knowledge, we'll proceed on further. We'll discuss about how to treat migraine. We'll start with acute migraine, guys. So acute migraine means patient is presenting up with symptoms. Chronic migraine, on the other hand, we can call it as prophylaxis of migraine. That is, after treating acute migraine, how do we prevent the development of further occurrences of migraine? That's what prophylaxis of migraine is. Here we are discussing about acute migraine, three major subtypes: mild, moderate to severe, or extremely severe like status migrainosus. If the patient is presenting up with mild migraine, the treatment of choice is going to be NSAID virus. The treatment of choice is going to be NSAID with or without paracetamol. With or without paracetamol, that will be the treatment of choice for mild migraine. What is NSAID? Non-steroidal anti-inflammatory drugs. But sir, paracetamol comes under that classification. Why are you calling it as a separate one? Don't mix it up, my dears. Paracetamol is a non-NSAID agent. which means non-steroidal anti-inflammatory drug, right? Paracetamol has got a very poor anti-inflammatory potentials. It is a good analgesic. It is a good antipyretic. It has got very poor anti-inflammatory potentials. That's why usually we can give a combination of ibuprofen in combination with the paracetamol, a commonly used one in practice, if a patient is presenting up with mild migraine symptoms. But what if the patient is not responding? What if the patient is not responding to NSAIDs or even paracetamol? Then we can add triptans. We'll discuss about triptans in the next page, guys. Don't worry. We can add triptans along with NSAIDs. Triptans usually are not been recommended to be given as monotherapy. On the other hand, if a patient is presenting up with a moderate migraine or somewhat severe migraine, patient cannot tolerate up with the normal NSAIDs itself, then we can start the patients directly on triptans with or without NSAIDs. With or without NSAIDs. So you have to write down this flow chart, guys. If the question has been that drugs for migraine or treatment for migraine as a short note, you can simply write up this flow chart, and the next I'll be giving you a mnemonic. Remember the prophylaxis of migraine too. Just write down these two, that would be enough. If that question is going to be happening in the long answer ones, you have to write down the pathophysiology, acute migraine, and chronic migraine treatment process. Triptans with or without NSAIDs, and again, if a patient is not responding to even triptans or even NSAIDs, then we can add a drug called as lasmiditan. Then we can add a drug named as lasmiditan. We'll discuss about all these drugs in a few minutes, don't worry. On the other hand, what about status migrainosus or severe migraine? If the pain is lasting up for more than 72 hours, pain is lasting up continuously for more than 72 hours, it is not getting weaned off. In those conditions, we have to administer ketorolac, metoclopramide, because mostly patients might land up in severe vomiting, and you might need to be adding up IV fluids. All these are purely for the treatment of status migrainosus or severe migraine, which is usually not responding to NSAIDs or even paracetamol. This is the flowchart, my dears. The first, as I've told, a diagram, a flowchart, right? And that flowchart is nothing but treatment for acute migraine. Now we'll discuss about one or two clinical features of the pharmacological perspectives regarding those drugs. We'll start with the first one, 5-HT1B, 1D agonist agent, which are triptans. As we have discussed previously, triptans will be the first treatment of choice for moderate to severe migraine, not for mild. Mild, the treatment of choice is going to be NSAIDs. Okay, first of all, what is this 5-HT1B, 1D, and how do we remember it? How do we link it up with triptans? I'll give you a mnemonic, my dears. Just remember with this mnemonic, bad trip. Just remember with the mnemonic, bad trip. B and D. 5-HT means 5-hydroxytryptamine. Also, the other name for that is serotonin. So, serotonergic receptor 5-HT1B, 1D agonist agent, and that drug name is triptans. Well, this is the mnemonic for that. Bad trip is the mnemonic for that. Good. Now, one more point. Where is the receptor situated and how we are going to be utilizing it for the treatment of migraine? As we have seen over here, trigeminal nucleus on this surface. On this surface is where your 5-HT1B, 1D receptor is. This is a GI receptor, my dears, thereby that will inhibit the release or inhibit the exocytosis of the contents of trigeminal nucleus. Thereby, it can be used for the treatment of migraine. Now here, because when CGRP or substance P is not getting released, what do we expect? The opposite of these things is going to be happening. Vasoconstriction and analgesic property. Well, that is the mechanism of triptans, guys. So triptans, as we have discussed, this is going to be producing vasoconstriction. It's a vasoconstrictor agent. Because vasodilatation is the reason for migraine. Now, for the treatment of it, we give a vasoconstrictor. This can be used only for acute migraine. It cannot be used for prophylaxis. It is not used for prophylaxis or for prevention or for long-term therapy. Only for short-term therapy, we can use triptans. Why is that? It's because of the adverse effect profile. Why is the adverse effect profile very much severe? Because of this particular property again, which is vasoconstrictor property. Because it is a vasoconstrictor agent, it might be producing paresthesia in the periphery. Chest pain might be developed because the coronary arteries might get constricted. Whenever it is given along with an SSRI, selective serotonin reuptake inhibitor, an antidepressant agent, or SNRI, serotonin norepinephrine reuptake inhibitor, antidepressant agent. And monoamine oxidase inhibitor, multiple different uses are there for monoamine oxidase inhibitor. Whenever this drug is given along with any of these drugs, patients might land up in serotonin syndrome. All these adverse effects itself are very much important. You might land up in a 2-mark where the question might be adverse effects of triptans itself. Rarely, because it is a vasoconstrictor agent, the patients might develop coronary artery vasospasm. Patients might develop coronary artery vasospasm, and some patients might land up in transient myocardial infarction, or transient MI might also be developed in it. While these are the different classical features of 5-HT1B 1D agonist agents or triptans. Moving on to the next drug, we have CGRP antagonist agents. As we have discussed previously, what is CGRP? Calcitonin gene related peptide, which is a vasodilatory vasoactive peptide. Because it is producing vasodilatation, patient is landing up in headache or migraine. So for the treatment of it, you administer a receptor blocker agent or an antagonist agent, which itself will be producing a vasoconstrictor property, as simple as that. Ibrogepant, Gepant means CGRP antagonist. Gepant means GRP antagonist agent. Ubrogepant and rimegepant are given via per oral route. Zavegepant is given via nasal route. This route of administration and these drugs are extremely important. Now the last one is what? 5-HT1F agonist agent. 5-HT1B 1D is for your triptans. 5-HT1F agonist agent is lasmiditan. This lasmiditan, one advantage is it has got no vasoconstrictor property. It is purely more oriented towards the analgesic property, and that's the reason why this can be given even if triptans are contraindicated. This can be given even if triptans are contraindicated. So again, if a patient is not responding or if the patient is we cannot administer triptans, we can opt for lasmiditan. Adverse effects, because it might be acting up at serotonergic levels, patients might land up in dizziness. These are the classical features about drugs which is used for acute migraine. We'll move on to the last session of this, last part of this, drugs used for migraine, prophylaxis of migraine. We have a mnemonic here. Batman's car is the mnemonic. B is for beta blockers, guys, which includes metoprolol, propranolol, atenolol. Most of you would be knowing it. If a drug name is ending with LOL, it is a beta blocker. Well, these drugs are contraindicated if a patient is a known case of bronchial asthma, or the age of the patient is more than 60 years, and if a patient is a known case of a smoker. Again, these drugs are contraindicated for prophylaxis of migraine. Commonly, the drug which we use in practice is propranolol, guys. We have a famous brand named as Inderal. Propranolol is a common one which is used for prophylaxis of migraine. But of course, apart from that, we can also administer metoprolol and atenolol. Okay, Batman's car, BA. A is for antidepressant agents. Antidepressants like amitriptyline and venlafaxine. Amitriptyline increases suicidal behavior. Suicidal thoughts would be higher with amitriptyline, and adverse effect of it. Venlafaxine itself might be associated with hypertension, and patients might land up in seizures too. These are the adverse effects of these drugs. Batman's car, B is over, A is over. Moving on to the next one, T. T is for topiramate. Topiramate itself is an anti-epileptic drug. Apart from this topiramate, apart from this anti-epileptic drug, we have other anti-epileptic drugs like gabapentin. We have gabapentin and valproate. All of these are anti-epileptic drugs which are used for prophylaxis of migraine. Out of this, the most commonly used one, topiramate, might be associated with weight loss. Actually, it is not an adverse effect, guys. For some patients, it might be an uses also. Weight loss, and topiramate might also produce cognitive dysfunctions. Cognitive dysfunctions, learning disabilities, or memory disabilities might also be seen with that. Especially we used to call it as naming difficulty, which is commonly seen with topiramate. Two important adverse effects, guys, weight loss and cognitive dysfunction. Batman's car, BAT is over. Moving on to CAR, CAR. CA is for, again, calcitonin gene related peptide. We have the same set of drugs which can be used both for acute and for prophylaxis of migraine. but the drug names are a little bit different. CGRP related drugs, we have a mnemonic, remember that, which is FEGAR. What exactly are those FEGAR? F is for framenezumab, erenumab, eptinezumab, that is for E, and G is for galcanezumab. A and R is for atogepant and rimegepant. There, the same gepant we have seen, but the drug names are a little bit different there. We had ubrogepant there. Here we have atogepant and rimegepant. What's the difference between these drugs, buddy? See, consider here is where your blood vessel is. Consider here is where your blood vessel, and on the surface of it, we have the CGRP receptor. This is your CGRP receptor. This is your CGRP molecule. This molecule in turn will bind with the receptor, thereby that is responsible for vasodilatation to occur. That's the common thing. That's how CGRP is producing its mechanism. These molecules which we have discussed over here, FEG, which are MAB drugs, monoclonal antibodies, will come and bind with this CGRP molecule and tend to inhibit it. Whereas on the other hand, the gepant drugs, which are antagonist agents, these drugs will come and bind with the receptor and tend to inhibit the receptor's action. That's the primary difference between CGRP monoclonal antibody and CGRP receptor antagonist agent. How much important are these drugs? April 2024, remember this, my dears, April 2024, the American Headache Society has released guidelines where they have told that this CGRP antagonist agent or the monoclonal antibodies would be the first line therapy of choice for prophylaxis of migraine. If the patient is affordable, this will be the first line treatment of choice. That much effective, that much efficacious are these drugs. Okay, that's it about CGRP antagonist agents. So Batman's car, CA is for calcitonin gene related. One more CA is there, which is calcium channel blocker. Calcium channel blockers like verapamil and flunarizine. Flunarizine is actually an antihistaminic agent with additional calcium channel blockade property. But how come, sir, these drugs are being used? Because calcium channel blockers will be producing vasodilatation, right? How come these are being utilized here? This is what the important point. That's why we have explained about the pathophysiology here itself. You remember that here we had sodium influx and we have calcium influx. This particular calcium influx is getting inhibited by the calcium channel blockers. So this is nothing but a P or Q type calcium channel blocker like verapamil and flunarizine. Well, that is how it's been used for prophylaxis of migraine. So we'll move on. Here we have a calcium channel blocker, which is verapamil and flunarizine. This are P and Q type calcium channel blocker currently being used for prophylaxis, not the other drugs. The other drugs will be having peripheral activities too. This drug will be having more of a central activity. Batman's car, B is for beta blockers, A is for antidepressants, T is for topiramate and the other anti-epileptic agents. CA is for calcitonin G-related peptide, one more CA is for calcium channel blocker, and R is for RAS inhibitors, renin, angiotensin, aldosterone system inhibitors like lisinopril. This is your lisinopril and candesartan. Lisinopril and candesartan. These two drugs are being utilized for the prophylaxis of migraine.